It's probably backwards too.
And it's another we're together again. But
Together again.
before we hit the intro, we're brought to you by Crown Point and
Oh, and don't forget to get some tasty diet drop bread, big gay brand from Kroger.
This is not a show and might not even be a connection. Here's Judah and guest.
my guest today. I'm pleased to be with Jay Nass again. Of course, we did the Chickenfoot podcast, getting a little comedy in there.
Oh yeah,
And today he's with me to get a little more serious, but I'm sure we'll have fun.
that's why I grew
To
my
talk
beard longer.
the
Period.
distinguished beard. But
Except for my mustache is tickling me.
a lot has happened since. Of course, one thing that's happened since the last time I talked to you is you got better audio visual.
A lot better. Yeah, I was just using
Wow,
my cell phone. Now I'm actually using a computer.
nice,
So there you go. That's helpful. And I got better internet service. So
beautiful. Well, as some of you may not know, Jay Nass is Doctor Jay Nass,
have an MD after
and
my name.
he is not only an expert in the old MD, but also we're excited to talk to him because you have like a master's in what is it called with the
My official master's title is Masters of Health Administration.
there we go.
It is a combined degree of public health
Mhm.
and business, because you get
Mm.
the public health individual is a person who does epidemiology and local public and population health. So
Mhm.
we study things like epidemiology. So I'm an epidemiologist who happens to be able to do business, because what happens is those people get hired and they get pushed into administrative roles running the whole business, and they're like so they decided to develop the degree called health administration, which is what I do. So I do a little bit
I, and it's perfect for what's
of,
going on right now.
oh yeah.
And so we I wanted to talk to you a little bit more. Last time was great. Got a lot of good information, and but a lot has changed since then. Some things haven't
we
changed.
are learning we're learning, and so it's you got to be humble with what's going on and not just be like, this is the way things are, because we don't always know that. So
Well, what reminded me to want to talk to you was a post you made a couple weeks ago about. I thought it was fascinating when you talked about
there's some light.
the saturation in science being so talking about masks and how people are worried that we're not wearing masks enough, but you say, well, we're pretty much at 80%. That's pretty much that is what were the terms you used? Let me
so
not butcher your own words there.
so you get to a point of diminishing returns, um, where if you do a little, you get a lot back or a lot out of it. Once you hit 80%, even if you hit 90 or 100%, you get less back or less efficacy.
Hmm.
So what Dr. Robert Redfield, not to be confused with Robert Redford,
Robert
Robert
Redford.
Redford, but Dr. Robert Redfield, the
Uh-huh.
director of the CDC, he said if we could get universal masking for 6 to 8 weeks, we would completely get rid of this virus. Well, when they did a little deeper analysis of what it meant to get universal masking, it meant at least 80%.
And we've
And
had it.
according to the CDC, April of this year, we were at 78%. By May, we were at 83. By June, we we're at 89. And we've kind of floated around that 70 to 80 plus percent now for months.
So we've beat it.
So we beat it, yeah. The problem I have with that is we know masks work. We know you
Huh.
should use them, but the problem is that when you put them in the general public, there's just too much variability. There's too many variables we can't control for. Not everyone has the self-control to practice the habits consistently that are necessary to make masks effective.
Well, but I mean, really, nobody has those habits, right? I mean, in everyday life,
I wouldn't say
you
no.
have it for
I would say most.
most people don't, right? Like you walking around doing normal life. Now, if you're doing surgery where everything is like super intense and
Yeah,
focused,
and you
right?
have people watching you. You have
Yes, and you could
surgical
get
nurse.
fired.
I've been in many surgeries, and I've actually seen 20-year vets either excuse themselves or be excused by the surgical nurse and say, "Doctor, you have to go and rescrub." And you know, surgeries aren't always as serious as you all think, as one might think, because
Right.
there's usually another surgeon there, and he can
Yeah.
pause in the surgery, step out, wash his hands, not wash his face, change his mask, all that stuff, and then come back in. There's
Yeah.
there's a whole, you know, it's not like he
Yes,
walks away and then the patient just dies.
right.
Uh,
Thank
Obviously, in
God.
that scenario, you know, they might make
Yeah.
different decisions, risk versus
Yeah.
benefits. But I'm just saying that even 20-year vets mess up and touch their face. Now, in surgery, you can't drop your hands to your waist, and you can't bring them up to your face.
Yeah.
I mean, so that's called violating the sterile field. And what you see in public is people, you
Oh
know,
man. Well, that was. Do you
their
remember
mask.
Ford Sue's?
I happen to have one right here,
Oh,
where
oh,
you know,
oh,
where they're down here,
oh
they're
yeah.
down here, and
Yeah.
you know,
It's ridiculous.
God knows how long I've had this mask. Yeah,
I mean, and most people just
right.
have like, like a millimeter of cotton. So I mean, I'm not sure what that does.
Well, the the theory is that the virus primarily travels in droplets still
Droplets. Yeah.
the size of 5 micrometers and nothing less. Well, that's not true. But most of the time it does 5 micrometers, which is actually pretty big. And,
Mhm.
you know, tissue can easily stop that. Um, so that's just the primary way. It's not the only way. You certainly can distribute this virus through touch. And
Yeah.
what they found using air and fluid dynamics, that in small spaces, crowded spaces that aren't well ventilated, for some reason the virus can now float around and be in
Mhm.
much smaller droplets.
Size.
Yeah,
Oh.
and so when you're in a small room, they're also more concentrated. Now,
Well, and just by the nature of being in a small room, people aren't in a small room unless they're doing surgery or something like that.
correct.
They are answering phones, they are talking to each other, they're
They're eating,
touching
they're
each
drinking.
other, eating, drinking. Yeah, they're this is Ford Sue's when he originally he was originally very skeptical of the mask use because he had used masks very often as a carpenter in several areas and realized that it's almost impossible to keep a mask on in public the right way. It's just almost
Absolutely.
for a normal person who's not being watched, is not doing this and has procedure. It's just almost impossible.
It's very
And
difficult, and
especially if you have a beard like me, it
yeah,
is like
it's
it's
difficult.
impossible.
We touch our faces way more often than we even know.
Yeah.
And true mask etiquette, you have to wash or sanitize before you touch your mask or face, and then wash and sanitize after you're done touching your mask or face. Because every now and then you're going to have to readjust.
Yeah.
And when I was in surgery, I would have to say, "Nurse, can you push up my glasses or cinch up my mask?" And she'd have to do it for me because I'm sterile. I can't touch.
Right.
So
And it creates much more of a culture of and speaking of culture, I had somebody actually maybe well I won't name their names, but they
secret.
were adamant that masks are going to save us because they saved Japan. Now this was back before they were saying, Japanese know how, Asian culture knows how to wear masks, and you can look at them and you can see how masks have saved them, and then their cases spiked.
It's
Like,
a false narrative. We have masks. Well, let me just start with saying this: masks work, and you should wear one. But they work more on an individual level than a population level, because it depends on so many behaviors, and actually having access to a clean mask and access to hand sanitizer and access. You have to have things available to you. If you don't have resources, it's also hard to make it work. But here's what happened in Japan, and here's what happened in Vietnam, and here's what happened in Hong Kong and China and all these Asian places. First of all, we have decades and decades and decades of mask use in the general public that says that they make no difference. We know masks work in a clinic. We know they work in animals. They work on humans in a hospital and in these very controlled...
In certain settings, yeah.
Controlled
settings. Yeah.
Once you take it out of that setting, then you have a whole new set of variables, and you don't have this homogenous group of trained individuals and, this culture of proper mask use. You have anything can happen. And so what happens, because we're talking about numbers, over time, the average comes down to average. You get 0 point averages, nothing. Like,
no
all
net
the people are
gain
doing it right
from
and all the people are doing it wrong, it averages out to no difference. So what happened in Japan and what happened in China, remember, this particular virus is from China. And this is not a Trump thing or anything like that. It's from China the same way that kangaroos are from Australia and koala bears or panda bears are from China, right? That's where it lives. That's where it's from.
It's a fact.
And it spreads the way you can see some of the Asian culture spread. Philippines, Vietnam, and Japan. If you look at them, they all look similar. Not the same. There are some very significant
their culture. Yeah.
But the cultures and even the ethnicity kind of look similar. The virus spread in the same way. So because it's from China, because it grew there and developed there and evolved there, it evolved with the people there. So they're constantly being infected with all these different variants of coronavirus. And so over time, they develop genetic resistance from it, right? And they're a homogenous culture. I'm not sure. You told me your wife does some stuff in China. You go to China, you see Chinese. You don't see a bunch of white people and black people and Indians. You see Chinese. It's a very homogenous culture. And for a virus to mutate, it needs a challenge. It needs variability. And when you see the same thing over and over again, it just kind of, you understand? So what we had is we had an East Asian version or strain of the virus. And I just posted this on my Facebook page. You have an East Asian version of the virus. When it got to Europe and these other nations where we had variability in genetics, they all don't look Chinese, right? Variability in genetics, you suddenly get the European version. And that's where we got these epicenters of Italy and Spain just exploding. When the Japanese got the East Asian version of the virus, now they're having
they
trouble.
Defeated it easily.
Yeah, now they're big.
But the European one came back.
The European one came on. Now Tokyo's in trouble. So had nothing to do with masks. Now, if you want to talk about death rate, we know that obesity is one of the number one things that causes problems. How many fat Chinese do you know, or fat Japanese you know? Not many. They tend to be much slimmer and smaller than us because of diet, because of culture, and that's just talking about diet. And we're not talking about how things are spread. The Japanese don't shake hands; they bow. Now, if I'm going to touch you, that's going to cause some problems. The Japanese and a lot of these Asian cultures take their shoes off before they go in the house. Like little simple things like that.
And yet it's spreading so much in Japan right now.
Well, again, they now have this new virus, and so.
Yeah, I heard that what I read somewhere that the new UK virus is like 70% more transmittable.
So here's the problem with the UK virus and the South African virus. And I think I wrote this on my Facebook page. original East Asian virus and European virus only had a few mutations
Hmm.
that made it more virulent. Just a few. Uh, so it was no big deal. It only mutates at a certain point in the RNA sequence, and that was it. These new viruses, these new strains of the virus, have multiple mutations all over the place
Mhm.
that have made it more stronger. And that makes it what they call, I forget what they call it, something like a mutation strain of concern. Because
Well, yeah. What do you mean when you say stronger? Do you mean
strong,
more dangerous?
I didn't say, did I say stronger?
Yeah, you said it made it more strong. It made it
More,
stronger.
more, it had more mutations in more places.
Hmm.
Oh, and what I mean by stronger, yes, I mean more virulent, more easily passed on to another person.
So
Um,
maybe not more dangerous.
more okay. So far we haven't proven that they are more deadly. Uh, none of the strains so far have proven more deadly at this point in time. But
Okay.
new data is always coming out. So that's the good news is they're not more deadly. The bad news is even remaining the same level of deadliness, if they infect more people will die, but
Well,
not by
tell
percentage.
me, this is something that a theory that came across my mind. I haven't read it anywhere. Well, maybe I read something about it. I don't know, but it's something I've been thinking about is it seems to me because I was reading about the swine flu and the H1N1 and how, I don't know, this might be the same thing, but how deadly they were, but yet how less transmittable. And I wonder if there's some kind of correlation because the more
Yeah,
deadly it is, the faster it breaks down your body, the less you get out, the
that
less
that is
you.
that is absolutely true. If something kills you faster than you can spread it, then it's dead ended itself, right?
Mhm.
If you can live long
Mm.
enough to pass it on, then we got a situation there. But if you can't live long enough to pass it on, then it's literally hit its own dead end. Does that make sense? And
So
so you're right.
okay, let's put a pin in that because that concerns me with but to get back to Japan and Japan, the Asian, and and California and New York. It seems like all these places that they're doing social distancing, masking up. They are locking down more than anybody. They're the ones that are having the biggest rise in cases.
Yeah. Well, I think, and I hate getting political here. Masks have been terribly politicized.
Mm.
And it seems to me that if you're on the right end of the I'm kind of a libertarian. I don't even really want to take sides. I count
Yeah.
myself
Cool.
as a classic liberal. I mean, I believe in the individual, but that's a
Okay.
whole another scenario. But it seems
I
if
like
you're
that.
on the right end of the spectrum, don't wear masks. You're a sheep if you do, or they might actually harm you. And if you're on the left end of the spectrum, it's a sign that you love your neighbor, and masks are the silver bullet. Uh, I go back again to Dr. Robert Redfield, who said if we mask up, this will be gone in 6 to 8 weeks. And he even said that he feels like masks are even more powerful than a vaccine, assuming that the vaccine was not 70% effective. Right now, we're talking 95, 94, 95. I say all that to say this. Some of them actually believe because I'm masking, that's enough. They're not social distancing, even though they're supposedly locked down. I've seen where they've kind of gotten around some of these things, like, oh, oh, this is what we'll do. We will put a plastic tent completely enclosed outside of our business, and see, we're offering outdoor venue. It's not ventilated, it's heated, and they're gathering together. It's like, no, that you need to be out in sunlight and you need ventilation. If you have a completely enclosed plastic tent because the restaurant's locked down, that's just another building, and they're
It
not
almost
doing
seems
it
like
right.
you could ventilate better in a normal building, in a normal restaurant building.
So, well, um, hospitals, for example, when they consider architecture and where to put patient rooms, you'll find that you can walk down halls of hospitals and not actually see a single patient room. you have to get on the unit, which is usually there's a code or a key swipe, and the units are offset. In the air conditioning, yes, there's HEPA filters, special HEPA filters. The air conditioning is designed to make the airflow in certain ways, and inside some of the ventilation, they actually have ultraviolet lights that kill anything that passes by. And so you have some architecture going for you, some technology working for you. This is why there's also things called negative pressure rooms where the air conditioner kind of sucks instead of blows. And so when you open the door, it would draw air from the outside rather than blowing air out into the corridor.
That makes a lot of sense.
We use these particularly with tuberculosis patients. You can't do that with restaurants if they aren't already designed that way, and you need a special.
But you definitely can't do that with a tent.
No, but what you can do is have a tent without walls. Okay, not a
but not where it's cold.
Tent. Well, yeah, but I've lived in Memphis for 20 years, almost 20 years, and almost everywhere has an outdoor venue. Almost everywhere. Of course, Tennessee has relatively mild winters, and they have these huge like heaters, these propane heaters, and you can go outdoor and feel just fine with these propane, and they're huge too. And that's perfectly fine. You're outside, you're under the sun, there's a lot of air, you can properly separate and keep that physical distance.
Yeah.
That's fine. But I've seen these people take these little loopholes in these states. And remember, New York's very densely populated. Tokyo, the most densely populated city on earth, I think. And so, there's that going for it too. You can't get away from other people.
Well, but so the business side of you, right? The administrative side of you must really sympathize, though. There must be sort of a war in you, especially since you have such a business versus health dualistic degree.
My present wife owns a business. She's a third owner of a business, and so we deal with that very, very personally. But fortunately, her business fosters more to young people, children, and so they're a special case concerning this virus because children tend to have some, I don't want to say immunity, but resistance to this virus that's natural to them, that an adult would not. And it's on many different levels.
I've noticed it's not just children, it's children and women. Men in general, it seems to me, I've watched as 40 plus people around me have gotten sick with it and been diagnosed with it, and the looking at like all the families, it's always the dad that gets hit, and then the kids are like nothing, sniffles. Then maybe the mom loses her sense of smell, sense of taste. I'm like,
I wasn't really prepared to talk about the difference between men and women, but I'm going to go out on a limb here and say that just using my professional knowledge, cardiac disease, strokes, heart disease, usually women are far less than men until they hit menopause. We know that a lot of those strokes and cardiac disease are a matter of having blood clots in blood vessels around the heart and in the brain and stuff like that. We also know that the coronavirus tends to cause a lot of clotting issues. The reason why women don't have all the cardiac issues and stroke issues until their 50s is because the extra estrogen. And what estrogen does is it helps you, it interacts with a thing called VEGF. And that's a basal epithelial growth factor. And it basically tells your body to grow extra blood vessels around, say, your heart. So if one blocks off, so what? You got all these other ones to work for you.
Oh,
and
interesting.
You can see how that might be important. Say you get pregnant, and you have this volume expansion, and you need to be able to grow more blood vessels to support
That's
baby.
the other thing I saw. The women that had been all the women that had been pregnant at one point, nothing happened to them. But it was in particular, I was like, why didn't these particular women, every single one that got hit that I know
Mhm.
bad, were like put down with a fever, hadn't been pregnant.
Yeah, like I said, I can't quote any research right now on that, but I'm telling you that it probably is related.
Yeah, that makes a lot of sense.
Right.
Yeah.
So, I mean, there you go. I wish I had I known ahead of time.
Well,
I probably could have pulled a
I'm sorry. Yeah. Well,
out and shown you, but I can tell you pathophysiologically that's how some of those things do tend to work.
I heard something about testosterone being important to like the CD8, the CD4 somethings. Testosterone is like it helps with or either helps or hurts. I couldn't tell with was it anti-inflammatory stuff.
Um,
Do you know anything about that?
so that's a lot more complicated.
Okay, never mind.
Testosterone directly acts on something called interleukin 10, which acts
Yeah, the
directly on
interleukins.
CD4 cells. Um, but I can talk a little bit about CD4 and CD8 cells. So most of your public knows about antibodies, and they may now have heard a little bit about neutralizing antibodies. And in your older vaccines, I said older, I should say more traditional vaccines, we're injecting literally the protein or a weakened virus directly into your arm. Um, Antibodies are made by B cells, B lymphocytes, B white blood cells. And what happens is um, antibodies tend to be garbage collectors. They look for things in your bloodstream. They look for stuff just hanging out in your interstitium, is what it's called, between cells, between tissues. And then they glob onto it. They'll mark it so another part of your immune system called complement can attack it, or so that other macrophages and stuff can come in and eat it. So CD4 and CD8 cells are more for your host cells. Your antibodies don't typically attack your own host cell. But CD4, which is T helper cells, and CD8 are cytotoxic cells. They basically can bump into the cell, explode, and they gush out all these chemicals and stuff that destroys the cell, or they'll get macrophages to come in and eat that cell. Saying this cell
they kind of like identified that, hey, this cell needs to be destroyed type thing.
Well, in both ways that happens. You have a cell that'll bump up against garbage in the interstitium, and there's a thing called an MHC, major histocompatibility complex. It's basically where the cell knows, is this me? Is this self or not self? If it's not self, then we need to get rid of it. Or,
alert.
And then it bumps up against the B cell, and the B cell goes, what am I supposed to make? Oh, that thing that you're holding right here in your major hepatocompatibility complex, your MHC. Okay, we'll try and make that. And then so it starts making things that look like that, and that'll glob onto the garbage and eat it. Well, once you have memory for that, you kind of skip the middleman. It goes, oh, we know what that is. We already have a bunch of those made. Throw it right at it.
Interesting.
The same thing happens when your host cell, your own cells, will display a protein on its outside. So this happens sometimes when there are viruses inside the cell and they're making pieces of themselves. Because remember, the virus is actually a piece of RNA or DNA wrapped in a little envelope, and there's little spikes coming off it. Well, what happens is those spikes go out to the membrane, and
The ACE
and then
receptors, right?
well the spikes go out. No, the ACE receptor is a little bit different. The spikes
Okay.
go out to the membrane if they're made inside of your own host cell using your own ribosomes. This is what this virus does. Little spikes, the external envelope of the virus, the little proteins go out to uh, the cell membrane, and then what happens is then the RNA is made and it goes into that little pocket there and it buds off, and now you have the piece of the membrane that's bud off with little spikes on it with RNA on the side. So you're actually kind of budding off pieces of your membrane because these little proteins go out to the edge of the membrane and just hang out there.
It's like little. It's like little. What's that movie with Gizmo? The Gremlins. It's like little Gremlins.
Well, but
replicating.
They become part. Yeah, they become part of the whole. And so, what happens is your immune system sees these things hanging out at the edge outside of your cell membrane. Go, that doesn't belong there. They bump up against it. Go, that's wrong. We need to send a CD4, CD8 cell there to go and eat it and destroy it. Your antibodies don't really do that. They don't really like to attack host cells. I'm not saying it happens zero, but that's not really their job. Now, every now and then, one of these little proteins will break off and float around in your system, and that will activate your B cells, not your T cells.
I wonder if testosterone has. I'm curious if testosterone or inversely, estrogen has anything. I think it might be more what you're saying. The vascular. What did you call it? Where the makes more where estrogen makes more veins.
Stimulates something called VEGF.
VEGF. Okay, yeah.
Basal epithelial growth factor. VEG.
That probably gives more avenues for the blood to flow and that sort of thing. I don't know.
Possibly. I think what you're thinking about in the testosterone is there may be a relationship between interleukin 10 and activating CD4 and CD8 in this thing called cytokine storm.
And the cytokine storm is what hurts us, right?
Cytokine
with COVID?
Literally means cell movement. Cytocell kinesis movement, right? Cytocell movement. So it's telling your immune cells to move into an area. And if you get too big of a signal for movement, then you get a big, huge movement, and then you get just enormous inflammation, and that can lead to, respiratory failure. It can lead to, basically shock, and you die. It's not good.
Wow. Interesting. That may be a way that testosterone could play into it, but
like I said, testosterone probably helps create that cytokine storm,
which could be good in some ways, but with COVID could be bad.
How did that happen? Give me a minute.
What happened? You're still here.
Here. I must have unplugged my computer somehow. It's telling me that my battery was low. I'm like, how did that happen?
I almost lost you there for a minute. The cytokine storm was coming. All right. Well, that I think that's really important. Everything you just said, for those of you that are watching, we're getting awesome. I'm so glad to be able to talk to you, Jay, because you can really break it down in simple terms. Although some of these terms are big words.
Yeah.
But I think it's important to know these words. Yeah, Google them, write them down. Because it's important to know this, because this is exactly, that sets the stage for talking about the new kind of the RNA virus that we have now. And I want you to talk a little bit about that and unpack it for us.
You mean the mRNA vaccine?
mRNA vaccine, which is not actually the virus, right? It's like a weird clone of it.
So the virus, the coronavirus that we are that's around, makes 29 proteins.
Okay.
2 of them make up the outer surface of the virus. One of them is a spike protein, and one of them is a more variable region that's sort of the envelope of it. So that's not a real good region to make a protein, because that envelope region varies too much, and
Okay.
so because you can make that envelope in so many different ways, but the spike protein's a little more stable. So what they have done is they found that they kind of clipped out that area of the RNA, the recipe, the directions. You can think of RNA and DNA as sort of the book that tells the body how to make itself. And so this little piece of RNA says, this is how you make a spike protein. And every now and then you get a few little mutations on there, no big deal. But it's a fairly conservative region. That means it has some resistance to mutation and lasts
It
over a
wants
long
to kind
period.
of stay the same.
Yeah, it wants to. Like, I mean, if you look around at human beings, we all have, 10 fingers, 10 toes, right? That's because that part of our DNA is very conservative. It doesn't
Okay.
like to change. Yeah, there's
Yeah.
people with 6 fingers. Yeah, there's people with less, but in general, we all look similar, okay?
Hmm.
Now, things that vary a lot, eye color, hair color, where teeth form, stuff like that, that's highly variable, you know, but we're all gonna some of these things in our DNA is gonna look alike for a long time. Now our fingerprints are gonna look a little different, our retina is gonna look a little different, but you get the point. So
And
that
the RNA is the part that tells it what to look like, right? Or how to be.
well, your
It's the
DNA
code.
typically does, but
Okay.
you mean as far as as the virus.
The virus, yeah.
So RNA has a lot of jobs in the cell.
Hmm.
But we are talking specifically of something called mRNA or messenger RNA. And it is written a very special way that it can it doesn't go into the nucleus. So you have a cell, and inside the
Okay.
cell you have a nucleus. And that nucleus has an envelope too. It has a little kind of membrane around it. The
Hmm.
RNA does not like to be inside that nucleus. It doesn't want to be anywhere near the DNA. And if it is near the DNA, it wants to be pushed away from the DNA because its
Okay.
job is to carry messages from the DNA outside the nucleus into the cell to the ribosomes. So you can think of mRNA as being attracted to ribosomes, kind of like a magnet to your fridge. It don't want to go to the nucleus. So all this hooey about it goes in and changes your DNA. It doesn't want to be near it. The DNA has
Right.
too large of a charge that pushes it away, and
Okay.
so it's attracted.
I was wondering why you're going into detail about that. It's because some people think that it changes your DNA.
Mm-hmm. It doesn't
Ah,
want to go
okay.
anywhere near it, and so it stays in
What
the.
about Jurassic Park? No, I'm just kidding. Keep going. Keep
Well, in
going.
Jurassic Park, they said that it was DNA that they got, and
Yeah.
they probably did stuff what we call nowadays CRISPR, where you can go in and edit DNA and edit
Yeah.
RNA and stuff.
Yeah.
But we can stay away from that. So
Okay.
what these vaccines have done is
Mhm.
they've isolated the area of the RNA that will build this little spike protein, and so once this thing's injected into your arm, it goes into your muscle cells and maybe other areas of the body, and it's put in little droplets of oil, and that oil is easily eaten up by the cell, brings the RNA into the cell, and the RNA is attracted to your ribosomes that just their only job is to make proteins. And so it makes this little protein. Well, it doesn't know what to do with it, so it packages it and spits it out to the membrane. So it sticks outside the membrane and just sits there.
Hmm.
You might get one or two that
It's
break off,
fascinating.
but
Yeah.
then this is where your CD4 and CD8 cells come in and go, oh, that doesn't belong like that, and then they come and eat it. Now, both these, the Pfizer, BioNTech, and the Moderna, do this.
Right.
There are some others coming around like AstraZeneca and Johnson & Johnson that
Johnson
actually use
Johnson's
an
one I heard.
adenovirus. They use a chimpanzee adenovirus, which
What's that?
they're using a real virus. It's actually a DNA virus,
Oh, okay.
and this one
That's
does.
the one our friend is taking, I think.
It's not available yet. And
Oh,
if they're
okay.
taking it, I don't know where they're taking it.
No, I don't know if he wants people to talk, but a friend of ours, a mutual friend of ours, is in the where they're testing it. What's that called? Where they
Okay.
got the blood? Yeah,
That
I
one's a
think
little
it's the
different.
Johnson Johnson one.
What they've done is they've because they can edit DNA now. Since it's a DNA virus, what they've done is they've built DNA just means diribonucleic acid. Instead of having one, they have two, and
Two.
it's a little
Oh.
more complicated than that.
Yeah. Let's get out
RNA
of the
is
weeds.
different things. But the thing is
Yeah.
that this one is packaged inside a real virus, a
Yeah.
chimpanzee adenovirus that easily infects mammalian cells, but doesn't typically cause disease. Doesn't matter anyway, because they've gone in there and they've stripped the DNA, and the only thing that DNA is going to code for is it codes for an mRNA, which then wants to leave the nucleus and go build proteins just like
More
the mRNA.
proteins.
So
Yeah.
most of your RNA comes from the nucleus because it wants to escape and get away from the nucleus. Okay.
So,
And
so
so
what both of these do, one not being the virus, one being just the RNA of it, mRNA,
hmm?
they both create antibodies, right? They both tell those. Oh no,
Well,
what
they
do they
might
do?
create some antibodies. So
Okay.
this virus we've discovered seems to be more mediated by T cells
Oh.
than B cells. The public knows a lot about antibodies. Well, not a lot. They've heard a lot about antibodies. But these injections are not designed to specifically stimulate an antibody response. They're designed to specifically stimulate a T cell response. So instead of getting B cell memory or antibody memory, you're getting a T cell memory.
Now, to back to your analogy before, that's the one where you skip the middleman.
Memory is where you skip the middleman, where if you encounter it again, your body already has some cells or antibodies in reserve that
Okay.
already know what it is. Now,
Okay.
you're going to get some of the same response. If you bump up against a cell that doesn't know exactly what it is, because you have full range, it's going to do what it's going to do. It's going to try and create stuff and have middlemen. But because you have so many going around, there's going to be stuff. Oh, I already recognize that. I don't have to go back to this. I don't have to go bump around and get to other B cells and get permission to make antibodies. We're already on it. Boom, we know what it is. There's no middleman there.
Yeah.
But you're going to get a little bit of play in there. But for the most part, yeah. And that happens in both T cell and B cell responses. So what the difference is in some disease states, some viruses, let's say, I think it's measles. We haven't had to change. When was the measles developed? 1960. 63. We haven't had to change the measles vaccine since 1963 because the memory that it provides is so strong and so long lasting that we haven't had to change it. And I think that one's mostly an antibody or a B cell mediated response.
Okay.
AIDS is a T cell mediated response. Problem is AIDS likes to infect T cells, which are a very huge component of our immune system, and that's why you get immunodeficiency, and that's also why you can't give a vaccination against it. So you don't want a vaccine that encourages attacking your own immune system or your own immune cells. If you lose a few muscle cells, that's fine. Just make more.
What there has been I've seen people talking about how the coronavirus is similar to the AIDS. How is it similar to the AIDS virus?
It has a spike protein.
Just a spike protein, that's it?
Yeah. So the conspiracy theory goes like this. We created a coronavirus in the lab and we use the AIDS spike protein to do it. I'm like, problem is the coronavirus came first. We've known, I think the earliest we've seen the coronavirus was in the 1930s. We isolated in the 1960s. Everything we know about AIDS happened in 80s and 90s.
Yeah.
So
could the coronavirus have been mutated in a lab, and so maybe not created in a lab, but engineered to be worse or different in a lab?
Could they have toyed with the virus and made it worse in the lab and let it loose? Not likely. And here's why. We only know what to do with certain viruses because computer programs tell us. We enter in the RNA or the DNA code, and the computer kicks it out and says, here are the most likely areas to mutate, to change. These are the ones that are the most sensitive. And so any scientist in any government worth their time and money is only going to throw money and time at that, because you're not going to find the most, we were talking about conservative areas. Like, we're not going to attack a conservative area because it's too hard. They don't want to change.
But they could have stumbled upon it.
So astronomically improbable, not impossible.
Well, I guess
the
the best argument I've heard for it being made in a lab is that they've tried so hard, and I'm sure the Chinese would love to find an example of it in nature and just have not found it anywhere in nature.
Being tinkered with in a lab is different than being created in a lab. Strangely enough, there are things that nature does that we can't imitate in the lab. I mean, we see this in zoo animals. Like, some animals we can't keep in captivity. And come on, it's birds and the bees stuff. Like, here, we'll feed you, we'll give you a male and female together. Come on, make babies. And they'll die.
Doesn't work.
For some reason, something happens in nature that, even though we have all this knowledge, we just can't reproduce in a zoo or in a lab. And so when we look at it under the microscope, we can go, this happened in nature. It didn't happen in the lab, because A, we don't know how to do that. And B, we don't know how to do it that well. So if we're talking about actually developing this from ground zero in the lab,
I don't think anybody thinks that, right? That's impossible.
There's no way, because
but tinkered with.
Think about carbon. Carbon is an atom on the table of elements. When you look at these numbers on the table of elements, they're averages. Averages between the isotopes. You've heard of carbon-16, carbon-12, all these different carbon datings, because they have different numbers of little atomic particles inside of them. Some of them are more stable, and that's what labs use, because the other ones last for seconds. But in nature can find a way to use it where we lab techs or whatever scientists can't. And so when I look at something underneath a microscope and go, this is made out of all these little elements, these carbons that only work in nature and never in the lab, then we know right away that wasn't made in the lab. Can't, and because they have different numbers of particles in it, they weigh different, right? They have an atomic weight. And so we can just weigh it and go, yeah, something's not right there. They're using stuff that we actually can't do in a lab, can't make last in a lab. That's one way that we know things aren't developed in a lab, because we simply don't have the technology or ability.
And yet sometimes we think we know more than we know, right? I mean,
oh yeah,
every now and then.
We wish this was Star Trek.
Well, let's get a little out of the weeds and talk. So to finish off talking about not finish off, but to sort of continue talking about the vaccine. So we got very deep into the technicals of it, but what does it actually do? This one that is the mRNA and not the actual virus. You were saying that it builds T cells, but can you talk to me practically, in practical terms? What is it doing?
In practical terms, what it is doing is it is building a protein that it will now express. It tells the cell, build this protein. And once it builds that protein is expressed on the outside of the cell, just hanging out there. And that tells the T cells, attack this cell. Okay? Any cell that gets infected with this virus is going to build spike proteins. Well, we can just make the RNA build only spike proteins, not any of the other 29 proteins. And so the spike protein doesn't hurt us. But
so we build an immunity to it without having it in us. We trick our body into thinking we had it, basically.
Yeah. And I think that's another thing that I posted is there's a difference between sterilizing immunity and immunity that just prevents us from getting sick. You've heard of people being carriers of something, but not actually being sick themselves.
Yeah.
That's part of what some of these vaccines are doing. They're not actually giving us the virus. They're giving us the ability to make these spike proteins that the body recognizes and attacks. So it keeps any kind of disease or disease state down. And so we potentially can be carriers but not feel sick. So that's why it's important that other people get vaccinated. And just because we got vaccinated doesn't mean we're free to move about. Now, what it does do is it makes it less likely for us to shed virus as well. So it makes us less infective.
Well, we think it does so far.
Yeah. Well, and logically it should.
It should. It should. We don't know for sure. And that's where I kind of wanted to, that's what I wanted to talk about is my fear would be going back to what you said before. I said, put a pin in that the problem with the coronavirus is that, this sounds weird, is that it doesn't kill people fast enough. The problem with coronavirus is it's super transmittable. And since it doesn't break down the body so much, correct me if I'm wrong, it makes it super transmittable. People don't know they have it. People don't feel bad, and they transmit it until it transmits virally, goes viral until it hits somebody who can't handle it.
Correct.
Well, it seems to me, so the what I worry about this vaccine is that it'll continue that, and maybe even amplify that very problem with the coronavirus, is that it'll make it so that people won't feel like they won't have the symptoms, they won't get deadly ill, but they will have the virus, and it will continue to transmit until it hits the people that haven't had it yet, or haven't had the vaccine yet.
There is it's sort of a yes and no with that. The theory goes that, well, we already know that this is somewhat of an asymptomatic transmittable virus, which I actually have some problems with, because how do we know that? And I've been trying to get to the bottom of that a little bit, and I'm finding a lot of, well, they had a PCR test, and I'm like, but PCR tests just show exposure,
right?
Not actual infection and illness. Only a doctor, well, a provider, nurse practitioner, or whatever, they can determine that, and it takes more tests than that. But let's get back to it. If I give you the vaccine, and if the virus tries to take hold, your body will attack it and destroy it faster. And so we've been doing, our first vaccine was what, 1796? That was smallpox. So we've been doing this over 200 years. Okay. So this is not new science to us. And so the vaccine should slow or greatly reduce the number of virions, live virus, that can be shed and infect others. Especially if so we're not just being immune to it because our body is doing a good job of fighting it off. We're keeping its numbers down. So think about it, inoculation. In order for you to get sick with this virus, it doesn't take just one virus to do that. And I think people believe that.
You talked about last time. A virus load, right? Is what you said.
You need inoculation or viral load. And I believe the research says it's hundreds to over 1,000 viruses that are active and effective at the right place at the right time. So you need a certain concentration. No one's going to get drunk off of one beer, but they might get drunk off of 12 ounces of vodka. Okay, that's going to be much different than. So you have this higher concentration, right, in a large volume. That'll
bigger
knock
virus load.
That'll knock in your butt. But one beer, And so when we're reducing viral load, reducing viral shedding, then even if we are around another person, they might not get a big enough load from us to even get sick. And there is some talk that people who get just a little bit sick because they're only, they dealt with a much smaller viral load, which makes sense. There's a difference between trying to stop a toddler from running out into a street and try to pull my car back from if the gear went out and there it goes. One might kill you, the other one will just make you out of breath. Whatever. But I'm just saying the effort is different. And
but now the difficulty for me is that the people that are most vulnerable to this virus, I've seen more and more that they're saying don't take the vaccine. So pre-existing problems with immunity. That's not true.
I haven't seen that.
The UK put out like they had 2 people die and of the vaccine, and they said, well, they had pre-existing immunocompromised
I haven't seen that data
conditions.
I know that HIV was only done in the later trials. There are some very special disease disorders that you would never vaccine someone. Severe combined immunodeficiency is one of them. That's boy in the bubble stuff, where they don't have B cells and they don't have T cells. And why would you give someone a vaccine with that?
Right.
That's the wrong thing to do. Though, I guess if you gave them this vaccine, it would do nothing. But what it could do is it could make. No, I don't even know. I would have to look at the research, because as far as I know, they haven't been able to directly prove that the vaccine kills anybody. Not yet. That doesn't mean it's never going to happen. But a lot of these things I'm coming out and seeing, I'm like, well, that's population level. For example, we can and do predict how many heart attacks happen each year in our population. And I think one of the big ones was the Bell's palsy, and where we know that in our population, the United States population, that between 15 and 30 individuals per 100,000 individuals get Bell's palsy. We don't know what causes it. We have some ideas, but there was 4 individuals in one of the tests, I forget which one it was, that got Bell's palsy. I'm like, okay, well, how many individuals did they do the vaccine in? Well, roughly 20,000. It was actually 18,800 and something, but we're around the 20,000. Well, 20,000 is 1/5 of 100,000. And in 100,000, it's 15 to 30. So we can divide by 5. 15 divided by 5 is 3. 30 divided by 5 is 6. So we could determine that in 20,000 individuals, we can expect there to be between 3 and 6 Bell palsies happen just spontaneously. And there were 4 Bell palsies. So I'm like, well, I don't tell you that there's not enough. It's not happening enough for us to be like, oh, this causes it. Does that make sense?
Yeah, although, I mean, you're talking about comparing different population samples, right? Different when it comes to the sample versus a population, you're just comparing based on. Seems like you're just comparing percentages, right?
A good study, a good test, a good scientific test will have a population sample that most closely resembles the greater population. If it resembles the greater population, then it's going to have all these predictive values. It's so many people are going to die. So many people are going to have heart attacks just because that many people have heart attacks in the U.S. So many people are going to, whatever, fall in their kitchen. The more that we have some of these, so many people are going to be struck by lightning. In fact, that was actually listed on the Pfizer one. One of the individuals was struck by lightning, and guess what? It had to be reported as a possible side effect of the virus. You'll get struck by lightning. Not really. It's just that we know that so many individuals per year will be struck by lightning, and it's actually in a way comforting that some of these terrible events happen because it means, oh, our sample actually does look like the real population, and that's what you want. If I want to know how a drug works in just women, then I'm going to pick women. There would be no use for me to test oral contraceptives on men and women. That wouldn't make any sense at all.
Right.
Now, if I want blood pressure, I want the population of men and women. In fact, in med school, I remember I was on an internal medicine rotation, and they were talking about the efficacy of this particular blood pressure medication. And someone had presented this research, and and the doctor, the attending, pointed out, if you read right there, they only tested it in women over 50. Is this a woman over 50? No, it's a man who's 35. Then why would we apply that to a man in mid 30s? And everyone just looked at each other and went, "Oops," because you can't do that.
Mm-hmm, mm-hmm.
And so
Yeah.
you want your sample population to look like your broader population, or at least the
Makes
population
sense.
you're looking for an effect for.
It's got to be really hard, though. I mean, our broader population is really, I mean, it's really
Really
diverse.
broad.
It's really broad. We're talking about 300 million people, right? So, 350 or something. Right?
Well, I looked today, and the number of individuals that have received the dose is 9.27 million in the U.S. and 29 million worldwide. If there were some particular crazy side effect, you would see it rearing its ugly head now, unless it's long term and distant. And
which the coronavirus has, there's more and more research I'm seeing about what they call long COVID. What can you tell me about long COVID?
long COVID is really interesting. And we don't know everything about it, and it's important to try and stay humble with those kinds of things. But remember that this virus causes inflammation, and this virus causes little strokes. Strokes and inflammation are what we call a hypercoagulative state. Well, not strokes, but inflammation causes what we call a hypercoagulative state. You heard of your blood coagulating and causing clots, and we start talking about things like cytokine storm and all that. And this is a hypercoagulative state. It's going to trigger your blood to want to clot and coagulate. It's just what it does. So what happens with a stroke, a true stroke, like there's a difference between, let me see, infarction and, well, let's just do this. So a stroke is like you have your tube, right? Your blood vessel. And a stroke is a little thing comes on and clots it. Well, now no blood can get by. Now no oxygen or nutrients can get by. So everything downstream starts to starve and die. And if you have enough of those things downstream starve and die, it's going to take longer for your body to recover. And in some cases, it never will. It just shows scar tissue there, or you kill something that can't regenerate. And so that's what we're talking about with long COVID. You get enough of these little micro strokes, these micro clots, killing enough of these, areas, then it takes a much longer time to recover, if at all. And sometimes, and this takes us back to the estrogen and the VEGF, your body will literally have to develop another pathway around to feed that area, and that takes a long time too.
I've seen that on men too, where they have heart attacks, or they have so many heart attacks that their like body grows veins around their major vein or something like that.
So that's one of my stories from medical school. I had a St. Jude patient, and he was 69 years old, and he was the second or third longest lived patient of his juvenile cancer. He had lost a whole leg. It had metastasized. He was a fourth stage 4 cancer. He had lost part of his lung, but St. Jude had made sure that he checked in every year of his life, make sure that he was exercising and doing all these great things. I walk in there, I'm on cardiology, I'm doing my cardiology rotation. I won't tell you where this is at.
Yeah.
And I heard one of the nurses give his lab value, which was extremely, extremely, extremely high, and ask another nurse, should we call cardiology? Well, I was on cardiology. I stepped in between them. I said, where is this patient now? And and they took me to his room. The guy had been, oh God, so many balls were dropped. I mean, he was in active heart failure for, I don't know, 12 hours in the ER. It was ridiculous. And they did a stress test while he had chest pain, which makes no sense whatsoever. In the ER, I'm like, none of this is making any sense at all. Well, I had him on the table in 30 minutes, saved his life. But what really saved his life was his cancer, because St. Jude had made sure that he was so active that his heart had literally grown more blood vessels. So you can induce this activity by being active, like running, exercising, biking, you know. And granted, he had one leg, but he was very highly active, and his heart had grown so many extra
hopping everywhere
from his high activity, even though he had multi-vessel infarct, multi-vessel blockage. He still survived. And I was like, if he hadn't had cancer, he'd be dead. He'd be dead.
That's a great punchline. I love it.
The last time he was 14. That was his last operation. He was here 69 years old.
That reminds me of one of my biggest frustrations with how all this has been. Of course, I mean, who am I? But what I'm curious about is how come there hasn't been more talk about being healthy and people's vulnerability as far as being healthy. I mean, you talked about obesity being one of the number one things.
BMI, diet, exercise, because people don't listen. They don't listen.
But it's not just that they don't listen. You hear so much about vaccine. Once the vaccine gets here, we'll be saved.
Everyone wants to take a pill. I remember I was on a family medicine rotation, and I was doing clinical, and I had this wonderful family medicine doctor, and he pulls out his script pad. He says, I'm going to tell you something. I'm going to tell you a secret. This is a magical piece of paper. If I write anything on it, they'll get better. So what he was telling me was, if a patient comes to see you and you don't write a prescription for them, they leave feeling like you've done nothing, and therefore now they won't get better, even though you don't have to do anything.
But I think that does some of this have to do with the climate of our society, where fat shaming is a thing, and where, I mean, isn't there a place for doctors and politicians and, leaders of communities and pastors and us, to say, hey, this could kill you. Mm-hmm. Let's lose some weight. Let's start eating more, taking more vitamin D. I heard quercetin. Is that?
I don't know what you're
it's
saying.
Like, I'm not. QUERCETIN. Well, but like turmeric has some of the same. It's the stuff that allows the zinc to get into your cells.
Oh, for certain. Okay, it's a flavonoid. Okay, all right.
And how like there's just so little information about. People say take zinc, but the zinc doesn't get into your cells unless you're taking it with curcumin or turmeric or whatever this is. This
you do know that we need a little bit of arsenic, right? Not poison.
So eat some apple seeds.
Everything is a toxin. Everything is a poison. It's dosage that matters. You can die by drinking too much water, and and of course, the amount of time in which you drink it matters too. We usually aren't short on these things, and I'm all about homeopathic. Go ahead and make sure you have a balanced diet. Here's the thing about taking all these little supplements. Two things. First, there's no law that says that even has to be in it.
The what?
Yeah.
There's no law. What?
You go down and you buy Quercetin, where
Oh, that it's actually in
it
it.
actually has to
Oh,
be.
I see what you're
Well, it has to be in it, but there's nothing that says there has to be like a certain amount of it.
saying.
In a medication that's, by the FDA and all that stuff, it has to be 90 to whatever percent. It has
Yeah.
to, or you can't sell it. If it's a supplement, we'll just sprinkle in a little bit of this and a lot of that. It's like I don't know, people cutting marijuana with parsley or something. It's like
Yeah, I know. But I mean, we know like certain foods that have like turmeric has these things in it. We know
that's the second
zinc.
thing I was going to say. Since the space race and space age, we've been looking for, let's take a meal and a pill. Let's look this little pill. Like if you look at some of the old cartoons and old space stuff, like they take this little cube and they put it in the microwave and push a button, boop, it's a whole meal or something like that. Or they take it like, I'm full, I'm famished.
Well, they have it on the Matrix too. It's like just like a little soup that has all the vitamins you need, or something.
Well, but they're eating it. It's a whole bowl. It's not.
Oh yeah, that's right. Yeah,
it's not a little pill. So we have known for a very long time that it is much better to get most of your vitamins and stuff from everything that you eat. You're not going to get it from a pill. Yes, I know that sometimes we tell people to take vitamin D, and we tell them to take iron and stuff like that. But most of the time, we really encourage them to have better diets.
Yeah.
And some people get mad about that. They're like, I want to take a pill and be happy. I'm like, this isn't the space race. Sorry.
Well, that's what I saw somebody point out, the high confluence and correlation between those that were obese and low vitamin D. I mean, it just goes to reason that if you're not eating right, if you're eating a lot of sugar,
you can be fat and malnourished at the same time.
In fact, it's more likely that if you're fat, you're malnourished. Is what I've seen studies show.
That, but that may actually be a thing, because malnourishment just means bad nourishment, right? You're eating too much of one thing and not enough of another. And we've been pounding on eating a balanced diet for decades now, but no one wants to do it, and everyone wants to have that secret ingredient. Now let's eat kale. Now let's eat, I don't know, whatever the food du jour is. And you'll see it every year. There's always something that, if you eat this, it's a superfood. And, someone wants just a regular balanced diet. Come on. That's all you really need, and some exercise. In fact, they've done research on diabetes, and exercise is superior to diet. So you can literally control your diabetes, type 2 now, not type 1, type 2 diabetes, by exercising more. The more you exercise, the more crap you can eat.
Well, and it goes back to what we're saying about the cancer patient. They had him doing so much exercise, his body was creating more vessels.
But no one.
He was more healthy. He was ready for
exercise and eat well. That doctor did nothing for me. I couldn't do for myself.
Right.
Well, he told you
I get that.
He just gave you the keys to the kingdom. All you have to do is,
Yeah. Well, but do you think there's also a political aspect here, that we don't have as much control? And I mean, like, control as in we're doing something, like, as you were saying about doctors, the doing something factor, where, if we just get the vaccine, everything will be okay. I was talking to somebody the other day, and they were like, well, we are going to stay away from people unless they've had the vaccine. I said, well, I've already had COVID. And they said, well, it's not the vaccine. I was like, they do have the antibodies.
They do recommend that people who've had COVID to get vaccinated, because they've proven that you can catch it again. And also you can be a carrier and shedding virus, even with a vaccine. The thing is that
the vaccine, it can't be any stronger than actually having it, right? I mean, that's impossible.
Yeah, that's up for debate. And this is what I've tried to explain, is the vaccine is uniquely designed to activate T cells and T memory Where if you get the virus, it's going to give you a little bit of both, but probably more B cell memory. And so that's
Hmm.
different. And so you really want a multi pronged approach. You want to cover all your bases as well as you can. I mean, having had COVID, you don't have to get the vaccine. I would recommend that you do just as a booster shot, if nothing else, but also kind of make sure that you have good T cell memory, not just B cell memory, because we find that the B cell memory wanes faster than the T cell memory. And so there's that. But
I thought so. It's anecdotal. I thought it was interesting. My dad got real sick back in March after they'd been traveling to Nicaragua and all over the place, and I was pretty sure it was COVID. Like I have never
yeah,
experienced him being that sick, and he had like a loss of appetite. And everybody was like, "Yeah, everybody says I was really sick back in March." But then my mom got it recently, and I was like, well, this will be the test. Like they don't social distance from each other or anything.
well,
They didn't
no,
from us or anything. And
there
nothing.
is some truth that with severity of the disease, it could uh, make a bigger impression on your immune system
On your
and
T cells.
make it definitely remember better. You know what I'm saying?
Mm,
And
yeah.
for this reason, the last year or last couple years, they've actually doubled the dose of some of the doubled or quadrupled the dose of certain flu vaccines in older patients. We actually give older patients, people over 65, a stronger flu vaccine in
Mm,
order to evoke a stronger response from their immune system. So that because their immune systems don't work as well, so we try to get a stronger response just so they would have more protection and more memory, if that
mm.
makes sense. So what you're saying is somewhat true. If you had a really bad case of it, your body's more likely to remember it. Not 100%, but it's not a bad piece of reasoning.
Well, my wife barely had it, but she didn't get it either. We're not social. We didn't social
like
distance at all
like
from
you
her.
said, women tend to be immune to this stuff.
It is true.
Your wife's skinny,
Last,
isn't she?
yeah.
Yeah.
That's a real loaded question. Thanks a lot, dude.
Oh,
Yeah,
sorry, man. I haven't seen
she's
your wife.
skinny.
Well,
No, she is.
I saw her in Toccoa so many eons ago where
She's
I was that skinny.
she's healthy and athletic, and
My wife runs like a bird.
I'm skinnier than
Jaguar.
I've been in a long time. And when I got COVID, actually, I was probably the best shape I'd ever. I just started fasting. My wife and I started fasting. We started doing more exercise because we realized like we're not going to fight this by social distancing and masks. We're going to fight this by our immune systems dealing with it. And
There's
and
nothing
then
wrong with caring for your body and giving it the best opportunity to fight back. Nothing wrong with that. In fact, if I had one recommendation is if you're locked at home and can't get anywhere, gosh, get yourself a stationary bike or something. Lose some of that weight. Teach yourself lift some weights while you're sitting there doing nothing, and get yourself in better shape. If you can't do
yeah.
anything else, that'll protect you. We'll give you some protection.
Well, I agree completely. It'll give you probably the best protection, but that's up for debate.
Well, I'm
But
about multi-pronged approach. I like to try and protect on all levels.
I don't when it kills the economy.
Oh no, we know lockdowns work, but we know lockdowns have terrible consequences. You don't want to do that. And like I said, living in Memphis, everyone's got an outdoor venue. Everyone's got a patio, and all the patios are like dog friendly and all this stuff. And they all have these big heaters and stuff like. Yeah, if you can do outdoors in ventilated air and everything, go for it. I mean,
Mm-hmm.
not to get nasty, but if I fart in a car with the windows rolled up, you're going to know right away. If I'm outside at the fair, you may never even know it happened, right? Virus is the same way. You get in this tiny little enclosed space where there's no ventilation. It's all locked down. A bunch of people, everyone's going to know. Everyone's going to get infected. Everyone's going to feel it. You're out in a big
Believe me,
open area.
Everybody in my office, me and everyone else, we were in a closed area,
Right.
just breathing that vid. But what? So we got to wrap things up. What? The last thing I want to ask you is, well, if this vaccine is efficacious, when will we start? What? How will we know, and when?
Well, we'll see the numbers go down. When? So
But I mean, won't we naturally see the numbers go down anyways? I
we
mean,
are
with social distancing, with you know.
well because of this is a bigger conversation because of the replication number, which is also called the R naught, not NAUGHT. It
Mm-hmm.
looks like a capital R with a little zero next to it. Um, uh, it's too high. It's one of the reasons why we don't see a lot of flu right now. The R naught for the flu is very low. It's very close to one, and just a little. You get a lot of return. We've gone full circle. You get a lot of return for your buck. You do just a little cleaning of your hands, a little social distancing, a little mask wearing. You're gonna kill the flu. This guy, he's so big, right? If you do a little bit, it kind of brings it down here. Flu, you do a little bit, it's gone. Because it doesn't have far to go to get to zero. This has a
Yeah.
long ways to go to get to 0.
Mm-hmm.
So uh, it's
So how do we even know if it's working?
how we know we'll see the numbers go down, and we haven't seen them go down naturally. And one of the other, well, okay, you'll see that the more vulnerable populations aren't getting sick anymore. You'll get you'll start to get so. This is opening up the discussion to herd immunity, and that's a long discussion. But herd immunity is actually it's an equation, and the equation goes like this: herd immunity equals V sub C, which is equal to 1 minus 1 over R naught over efficacy of vaccine, because V sub C is vaccinated community. That's why you can't separate herd immunity from vaccines. But we know
Because vaccines is basically just accelerating the herd immunity.
Yeah, but anyways, longer conversation. But we know that the efficacy of this vaccine is supposed to be 95 or 94.1, depending on which one you get. The R naught, we're not sure what that is. It's a sliding scale. But if you listen to the numbers that Dr. Fauci is saying about how we need 80, 85%, that sets that R naught right about 5. And I've heard the R naught being around 2.7 something all the way to 7. He's setting it to 5. I believe he's being cautious because I think
it's probably a lot higher than 5, right?
No, it's probably lower than 5.
Lower.
R naught is lower than 5.
In other words, more people have had it.
R naught is basically the number of people that will get infected. If it's 1, it means I might infect one other person. If it's 5, one person infects 5, and another person infects 5 more, infects 5 more, infects 5 more.
But if most of the population has already had it or had the vaccine, then it's the knot goes down, right?
It would necessarily have to, unless the virus mutates in such a way as that it can keep going, and you don't want that. What you want to do is you want to dead end it as soon as possible. And since we don't really know what that R naught is, and it's going to be population specific, like you were talking about, how do you know if this reflects a population? Well, the population of Memphis is very different from the population of Clarksville. It just is. And so you may find a city or a state even, or a county where it goes away immediately. And you'll find some places that will just struggle and struggle and struggle for a while. And that's normal, unfortunately. So how we'll know it's going away is that we start seeing it disappearing in some of these problem areas and some of these more vulnerable areas. Then we'll just start seeing it disappear from those places. We have not seen it disappear naturally, not even with all the things that we're doing. And this has been going on a year now, and that's too long. So, but it's long enough for it to have good data. And the good data says this is only getting worse. And The other thing is we're seeing events. Okay, we had this holiday weekend where we know people are going to travel. 2 weeks later, boink. Okay, we've seen this other holiday weekend. 2 weeks later, boink.
But I don't think we
Yep.
did see like a big spike, did we?
We are seeing spikes 2 weeks, 2 weeks almost to the day of almost every little holiday weekend. 4th of July, even voting, the Tuesday voting. 2 weeks later, pow. Thanksgiving, 2 weeks later, pow. Christmas, we're now at 2 weeks later, and 3 weeks later, 2 weeks at Christmas and New Year's, we're seeing a spike. It just because it'll start to just start to level off and then go boink, like you know, and
In cases, right?
and deaths, cases and
Well, deaths.
deaths. You want to follow?
That's a much further out. Like that's hard to tell, right?
It's harder to tell. Plus, there's lag in the reporting.
Yeah, the lag is much longer.
So you'll see the cases, and then you'll see the deaths follow, and that's what we're seeing, unfortunately. And those things will disappear. You won't get those little bumps anymore if we're starting to see herd immunity. You won't see any kind of bump in this, and it'd be like, so a bunch of people got together, and then nothing happened. that's how we'll know.
Well, I mean, part of that though will necessitate, like, isn't part of the problem that we're locking down and everybody's staying home, and so you see these bumps because people are actually living, doing life together.
Yeah, one of the problems is being home. I mean, we've known this for a long time that the flu doesn't magically go away. Colds don't magically go away, but we have cold and flu season. And the cold and flu season is during the colder times of year where people start to go inside and gather together. Mm-hmm. It doesn't magically cure, I dream a genie, make a wish, and it goes away. The cold is still around. The flu is still around. Mm-hmm. It's just people are outside and away from each other and doing things outside. Mm-hmm. And there's sunlight and ventilation. But you very rarely. I've had a cold in the middle of the summer. It's happened. It's rare. I think I've had it like maybe 2 times in my life, 3, but so rare. So yeah, once we get to these colder months and people start gathering together, that's when you get these normal spikes.
But we talked about how even in these real hot places like Texas and Arizona, where they had last time, we talked about how the advent of air conditioning, real good air conditioning, and you add the factor of lockdown and sort of fear of in quarantine, you get the same effect of of winter, right? Everybody being in their homes.
Everyone being in their house, yeah.
Yeah.
And it's, again, like I said, just because it's hot doesn't mean it goes away. Plus, it's really virulent. It likes to jump to the next person. So even separating out a little bit is not going to have the same effect as separating out a little bit with a cold or the flu, because a cold or flu isn't that infectious. This is more infectious. So you have to work more harder to do that. And if you're not perfect all the time, you never know when that one time is going to happen. Or cold and flu, you can almost be blasé about it, but as long as you're doing something, you're relatively protected. Because it's just not that.
Yeah, well, that's interesting. Okay, well, let's wrap things up. But we got a few people in the chat. A lot of people have been watching, and Joe Priner checking in. Thanks for watching, man. Says, have they done autopsies on the bodies of the people that died of COVID?
Yeah, absolutely.
Have you seen any interesting findings or anything?
Mostly blood clots. Blood clots. That's what they find, like clot damage to the lungs, damage to the brain, damage to areas of the body that are very vulnerable to blood clots, like kidneys and stuff. And that's what we find. I mean, I'm not sure where they're trying to go with this as far as have they done. So the answer is yes. And what they have found is blood clots and inflammation and cell damage. A lot of it, our own cells hurt ourselves through cytokine storm. I think a lot of disease kills us because of what our body ends up doing, trying to protect us from it.
Yeah, it's weird. All right, then Jim Pass. Hey, Jim Pass is watching. Thanks for checking in. He's one of our loyal followers here on Not a Show. But he says thoughts about the efficacy. About the efficiency and efficacy of masks. Now, we talked a lot about that at the beginning of the show. What are sort of
efficiency and efficacy are two different things, but
what we said was they work really well in controlled situations.
Yeah, you can't just put everyone in the pilot seat and tell them fly this plane, but you can put a lot of pilots in the pilot seat and you're fine. And healthcare workers, people who are used to this, people who are not mask naive are going to do a better job. I can make my mask work for me and for you by always having a clean mask, always using hand sanitizer and proper hygiene and proper habits, not touching my face and stuff like that. I can make my mask work for me. But me and my wife, we sit in the parking lot of Walmart because we play this Harry Potter game. And it's the only place the little Harry Potter comes up. It's like Pokemon Go.
Yeah.
So
I've seen that.
We live 30 miles from everywhere. And so it's the one place we can
only
go,
place
and we'll sit there in our car and watch people pull their masks out of their pockets.
Like, that's where I keep mine.
Pull this out of my pouch. Okay. And look, I got another one. Look at that. I got two. How old are these? I don't know.
Yeah,
right? So
I haven't washed mine in I don't know if I've washed it yet. Yeah.
So if I at least change my mask every day, then that protects you, protects me. You have people who
people aren't doing that.
They're using the same mask. Well, it's about money and resources, right? And maybe just common sense. But if you go into a place,
just normal life
available, or are they sold out? So you got a person wearing a mask that they haven't been wearing for days, but weeks and months. Every time they went to Walmart, every time they went to church, every time
they're pulling it down, they're taking it off, they're scratching it. I mean, they're just
taking it up off the floorboards of their car, pulling it out of their purse, touching their face. I watch the only TV I watch is football, and I only do that because my wife likes football.
Me too.
And we see these guys, they're talking. As they're talking, the mask puts down, and they back up. Oh, okay, and they're touching their, as they're yakking away because their mask isn't fitting right. Yeah. And oh, by the way, you're supposed to wash or sanitize before and after every time you touch your mask.
It's ridiculous that they make them wear masks. How many deaths were in the NFL? How many?
These are also very healthy individuals. Now they have high BMIs, but it's because it's mostly muscle.
Well, that's not completely true in football.
Yeah, there's some big fat guys in football, but they're healthy fat guys who work out, and so they make their hearts work. And so guess what? They have more VEGF and more blood vessels, and therefore less blood clots, et cetera, et cetera.
Still, 0 deaths in all of sports.
Yep.
0 in all of sports.
Well, but you're also talking about an elite. You're not going to see a 65-year-old man out there, being a lineman. It's not going to happen.
No, but all the coaches.
Yeah.
And like we said, they're not wearing their masks right. They're not social distancing. They might be bubbling.
It's a very visual example of what's really going on. And
nobody's wearing masks.
And I've told you before that we have lots and lots. It's not that we don't have evidence. We have lots of evidence that says once you take masks and you put them in the hands of the general population, they don't make a difference. And by the way, this is cross-cultural. This has been done in Japan. This has been done in South America. This has been done in China. This has been done in the UK. This has been done in the US. And these are good studies that keep showing the same thing over and over and over again.
Fauci himself said it.
This is evidence that we have. It's not like we're not doing the studies. It's not like, well, we don't know what it does with the coronavirus. Well, we know what it does with SARS. We know what it does with MERS. We know what it does with the flu. We know what it does with tuberculosis. And oh, by the way, now we know what it does with coronavirus because it's been a year now. We've done these studies. It doesn't work. Doesn't mean you shouldn't wear a mask. It's just if you're going to do it right and educate yourself. There's plenty of YouTube videos out there. And don't touch your face. Wear a clean mask. Wash your hands. Don't do uh, don't don't do risky behaviors just because you have the mask on. Or I'm safe, I can go inside. I'm safe, I can go into this crowd. No, don't do any of that. I'm safe, I can go see grandma. No, stop it. Stay away from people. you know.
I don't know. I think if you're young and healthy, risk it. But Jim Pass says the data that I've seen on death says that death rate nationwide is flat compared to previous years.
So what I know what he's talking about. So people are talking about the CDC site and its death rates. Now these are some of the reporting that they have are lagged, and the CDC says that that it's going to take months to actually rectify all the data, and so they're talking from this year. But when you look at other websites that are keeping this data and not lagging behind, because the CDC wants to be perfect and they're checking every number, dotting every I, crossing every T before they're willing to post it, which is annoying. Like, I know stuff back in April, but I can't find anything in September, and we're in January. It's like, it's very frustrating. So one thing that actually spurred this particular comment, the data I've seen, death nationwide is flat compared to previous years. It's not. And there is a study that tried to use percentages rather than raw data. Now, we have 330 million people in this country. What's 1% of 330 million people? It's like, what, 33, was it 330,000 or something like that? No. Anyways, you'd have to,
I'm not
like
so
30,
good at the math.
Yeah, I'm terrible at it. I think it's like 300,000 or something like that. So the percentage is so small. If you use percentages, you're going to see a flat line. Look, it's only like a little bit of a percentage. What we're seeing is like 300,000 different. Well, actually now it's 400,000 different, right in that area, because we know some deaths aren't accounted for. We don't know why those people died, and we're still not there yet. We're still crunching the numbers. But if you look at the raw data, we do actually see the numbers that are different. If we look at the data that's using a percentage, you can't see the variation, because as a percentage of the whole population, it is flat. There's no.
Doesn't that sort of speak though to the minuscule? I mean, in from a certain perspective, the minuscule nature of the deaths in put in perspective of what could have been. I mean, you look at the Spanish flu.
Spanish flu is a very special situation, and people don't put it into perspective. They were harboring both healthy, injured, and sick people together in these tents, because a lot of it had to do with the war and stuff like that. And they're putting people. I got a gunshot wound. Oh, I'm sick with the flu. And then he gives the gunshot wound guy the flu, and then he dies.
Sounds kind of like New York and our retirement homes.
It's exactly the same thing. You actually put them in with people that were having a challenge to their system anyways, and you only have so much reserve until you get too many challenges and your body just gives up. In addition, a lot of those people during the Spanish flu died of pneumonia. One of the things that happens when you get a viral infection, especially a nasty one, an aggressive one, is it weakens your immune system. Your immune cells and lymphocytes and antibodies are all busy fighting this virus. And these bacteria that it would normally be able to easily take care of, it doesn't have any reserve to take care of them, and suddenly you get pneumonia and die. Well, the first antibiotic didn't come around until 1928. Long after the Spanish flu. And a simple antibiotic would have saved a lot of lives. And segregating out those who were sick with the flu and not sick with the flu, like if they had like a flu tent, would have made a huge difference. But that's not what they did. They just threw all these sick people together in the hospital.
And that's not what they did here either. They didn't learn.
Well, we do have COVID units. So we stick people with COVID on one unit, on one floor. We do try to do that, but how perfect are we doing that?
Well, thank you so much. Oh, by the way, Jim Pass says, thank you, Doc. And I want to say thank you, Doc. Thank you, Jim Pass.
All right.
And thank you, Joe Priner, and all the people who somebody else gave us. It was Jim Pass gave us a thumbs up, and lots of people watching. Thank you so much,
How many people are
Dr. J
watching?
Nass.
How come you can see that?
I got the special analytics.
Oh, you got the power. All right, man.
Thank you so much for being here and talking to me about it, and putting up with my cantankerous nature.
Well, I love answering questions on these things because they are complicated and they are confused by media and politics and stuff like that. And you know, masks aren't aren't the the silver bullet, but they're also not this death sentence and sheeple thing. So it actually is something a little gray and a little in between. And I think that's why we get confused, because there's some truth on either side. There really is some truth on either side, but people like to polarize. And I'm just here to say, no, let's weigh them both and just see where we sit. And I love doing that because I think that's healthy.
Well, I love doing this with you, man. I appreciate. I hope have you on again soon, just to catch up and talk a little bit more about it.
Yeah, sure. Sounds fun.
I do want to say my wife is beautiful and healthy, and
I never said she was fat.
I know you didn't. But I want to say she's not. I want to make that clear because I don't think I made it clear enough.
I did not want to get you in
Love
trouble.
you, Chanda.
That was not my motivation. I guarantee you that.
I know. Still put me in a weird position. Okay, so anyways, love you, man. I'm glad you showed up. Thank you, everybody, for watching. I hope you got something else. I know you did, because that was some dense, beautiful information. That is some raw material.
I mean, I took notes and everything so that I could say, yeah.
Oh, thank you. It showed, and I appreciate it, brother. All right, thank you, everybody, and tune in tomorrow night. Hopefully, Josh will be on. We'll see.
No one wants to see him. I'm just kidding. Nice to see you, Joe. Love you guys.
All right. Well, we'll talk to you guys later.
Take care.
All right.